harder to see stuff. So if you have access to a computer, that might be the easiest way, but we'll also be emailing out the resources that we share in the chat. So, don't worry about it. If you want to be able to see the PowerPoint slides, we'll put them in the chat so that you can open them up right now and follow along, but I'll also be screen sharing. And so there'll be lots of ways for you to learn and follow along, and you'll get the information. So really the intention is that we are as present as possible and we're able to listen and lean in and learn together. So thank you again. My name is Cody Russell and I'm the director of Kitsap Strong. It's an honor and privilege to be gathered together today. Although it's virtual, I do miss having the opportunity to be in the same physical space as all you amazing humans. We will do the best to create a virtual space that makes us feel hopefully a little bit connected, hopefully safe, so that we can lean in, learn, and have some fun together. I want to also acknowledge, we'll do a tribal land acknowledgement in a little bit, but I just do want to acknowledge that the land that we're on is a source of history, has history in it, right? That the way that we have lived on this land since time immemorial has influenced the caregiving and the caretaking of the land and the quality of the land and the waterways that we need in order to flourish. And so I just want to acknowledge the local tribes that have since time immemorial been stewards of our local resources. In my area and is the Suquamish tribe, Port Gamble Sklallam tribe, the Puyallup tribe, all helped steward the lands and waterways that my family now lives on and that we now get our food from and our resources from. So I just want to create the space for that. And I also want us to think about, as we start talking about trauma, think about the many potential sources for what that could look like in the lives of humans in our community. So we're going to get started. We're going to have some fun. I will take us through some PowerPoint slides. I'll also invite you to engage in some sharing. We'll either use the chat or we'll use another tech tool that I'll introduce to you in a little bit. But it might be nice just so people will fill the space with their identities. Go ahead and share your name, maybe an organization that you work for, and the community that you serve in the chat. So your name, organization, if that applies, and the community that you serve, and throw that in the chat so we can all see where we're coming from today. And as you're doing that, I'm going to go ahead and get us started. So again, thank you for this opportunity. We do think of this as a gift. So anytime we're able to gather together, we think of it as a social gift. And we want to honor that by starting on time, by ending on time, by treating it like it is a gift and something that we hold and cherish. And we want to create this space where we are able to lean in and listen to one another, where we're able to hear some new information, maybe be challenged in a good way. This curriculum is intended to be a little bit provocative, meaning that it leaves you thinking a little bit and questioning. We want you to advocate for your own learning. There won't be a formal break. We'll just kind of roll with it. And I want you to just feel comfortable turning off your camera, doing what you need to do, replenish yourself, refuel yourself, take care of you. Take what's helpful and leave the rest. Okay? So there's lots of great information here for us to all learn together. I also want to acknowledge that we try and create this space, the intention of centering learning. And in order to center learning, I think it's great to know enough about our brains and bodies to know what helps our full body be present for a conversation, our full brain be activated for a conversation. And one of the things that really helps our full brain be activated, we'll be talking about the hand model of the brain here. So the brain stem is responsible for regulation, and that's why I'm breathing, because I feel myself being a little dysregulated. Dysregulated is another way of saying I'm out of balance. I know that I'm really anxious. I'm really excited. I have a lot of content to cover. I probably don't have enough time. I tend to do this. I overplan for the amount of time. So I'm bringing that energy into this space, and I don't want to bring that energy into this space. So I'm trying to do some deep breathing. I'm trying to center myself. I was listening to some music right before we started, all in an attempt to regulate myself. And this next part of our brain, our fight, flight, and freeze part of our brain, is also responsible for relating to one another. Regulation, relationships, and then reasoning. So when we're feeling unsafe or when we are dysregulated, it's really hard to be rational. It's really hard to think through and problem solve. So if we don't feel safe, it's hard for us to learn. So we have these group agreements that we've cultivated through hundreds and thousands of these presentations where communities say, you know, we need a sense of humor, respect. Let's create a learning environment today where it's safe to ask questions. You can use the chat to ask a question, and Marlena will let me know if there's a question in the chat. You can take yourself off mute. You can ask a question. If something I'm saying doesn't make sense, I want you to feel empowered to say, hey, this doesn't make sense to me. And the reason why I want to start with that space is I'm also going to introduce one of my favorite quotes, and I forgot to put the slide in here, but one of my favorite quotes comes from George Box that says, all models are wrong, some are useful. What I mean by that, as I'm showing you the hand model of the brain, obviously our brains are way more complicated than our hand is. So if you think, hey, this is an oversimplification of our nervous system, of our brain, yes, right? But maybe this model, this hand model of brain, and thinking about it like this is a useful model. All models are wrong, some are useful. And it's from that context that I'm going to introduce two large models today. One model around this concept around the science of hope. And we're going to start there. We're also going to touch on another model, this 7 essential ingredients for trauma-informed care. And over the next several sessions together, we're going to be diving deep into those two components. And then we're going to touch on the first ingredient in the 7 ingredients, which is the prevalence of trauma. How prevalent is trauma in our community, and what are the different sources and types of trauma that might be impacting members of our community? All right, so we're going to start with hope. Knowing that we're defining something that's really complex, knowing that the model is flawed, my hope is that this model is useful. So when we think about this term hope, hope, as Desmond Tutu says, is being able to see that there's light despite all of the darkness. Another definition of hope is the belief that tomorrow will be better than today and that you have the power to make it so. Hope in this context is not just a blind belief that things are going to get better. Hopefully you hear in that definition, there's an active component to hope. It's a belief that things will get better and that you and your actions can actually help to create the better future that you vision. So does it matter when you're trying to accomplish a goal? Does it matter if you believe you will succeed or not? So if you're trying to do a task, do you think it matters if you think you can perform that task well or not? Throw it in the chat. Do you think it matters? Does hope matter? Does your level of hope? A lot, yes, a lot, yeah, okay. Beautiful. So I like to think of this, and I use this picture because I think it's funny, but I wanted to illustrate this point, is that I think that hope is a contextual experience, meaning that right now I'm pretty high hope. I'm pretty confident I can get through this PowerPoint. I might go a little bit over time, or I'll have to cut a slide here or there. But even if my internet cuts out, I know that Marlena is here with you, that she can help support me, right? We'll find a way forward. So I'm high hope right now because I've had previous experiences with Zoom. I've made it through this PowerPoint before. I have something to draw upon. Now, if you put me in the cockpit of a plane and tell me to land the plane, I may not be as high hope in that situation. I have no previous experience, right? It's a pretty overwhelming task with no previous experience to draw from. But So hope is contextual, but you can also nurture kind of a mindset, a perspective where you tend to see the opportunities even when you're faced with a new challenge. So for example, maybe you're thrown into the cockpit of that plane, but you think to yourself, I've driven a car before. I've learned how to do complex things before. There's probably an owner's manual here. If I can at least figure out how to get the headset on, I'm sure that there's somebody down on the ground that can talk me through the buttons I have to push, right? So maybe you can actually have even a little bit of hope, maybe not as much as you do for getting through the PowerPoint, but you have a little bit of hope going into that situation. The reason I use this picture is that high hope individuals tend to be able to take a step back and do that kind of contextualizing a little bit better. They tend to see the opportunities that are in front of them. I believe this young man is super motivated to accomplish his goals. He really, really wants to gain entry into this school. But because of where he's at in the moment right now, he is so focused and so maybe feeling a sense of frustration and feeling he's so close to the barrier that he can't even see the signs in front of him that tell him how to accomplish his goal, if that makes sense. So again, hope is contextual, but here's what we know. High hope individuals tend to believe that the future will be better. They believe that they have the power to make it so. They think that there are many paths to their goals and that none of their paths are free from obstacles. That last component is the most critical, I think, when we're talking about individuals who have kind of a higher sense of hope. Again, they acknowledge that their paths are going to be hard. If it's worth doing, it's going to be hard, but none, and that none of their paths are free from obstacles. And by looking at their world from that perspective, they anticipate, even before they begin, they anticipate that there will be obstacles. And that sets up a different perspective than if you think, if you're not anticipating the chance that there'll be obstacles, and the moment you see that obstacle, it's like that door that's slammed in front of your face and you can't make it past it. So here is hope theory in a nutshell. We have an expectation for a future goal. So hope theory from a researcher's context always involves these three components: a vision for some future goal, the willpower, the agency, the actual energy that you put into that goal, and way power, the steps, the journey, the pathway to obtaining your goal. Agency without a pathway is a wish. So when we use the word hope in our normal language, we may be using the hope in a way that the researchers don't define it. Like if I were to say, man, I hope it doesn't rain today, I have a goal, a future state in mind. I want a sunshiny, beautiful blue sky. I have energy that I'm willing to deploy to that. But I don't have a pathway to changing the weather. So that's really a wish. I wish that it's a sunny day today, but I don't actually have a pathway to accomplishing that goal. So I want us to acknowledge that hope in this context is a way to think about a lot of human behavior. We can think about human behavior from this goal-directed perspective. Sometimes those goals are cognitive goals, meaning you are intentional around your goal pursuit. I want to get my GED. I want to graduate from high school. I want to go back to school and get my master's. That might be a very cognitive goal. You've got an endpoint in mind. You've identified the pathway. Okay, I got to apply to school. I got to do this. I got to take this class and then that class. And you're showing up to each class, right? So that's the energy that you're applying towards that ultimate goal. But you may also have a goal that is, instead of unconscious, because from a neuroscience standpoint, we don't really know where the unconscious exists. Instead of that term, I want to introduce neurobiological, meaning that it's kind of a regulatory goal or a relational goal, not necessarily a rational goal. So you may have a goal to just feel safe, and you may do things to feel safe or feel connected. And you may not even realize that that's the goal of your behavior, but that may be what's motivating you in the moment. And you may be doing things just to feel safe. So sometimes that might be pushing people away because people have hurt you before, right? So maybe the goal is relational, or the goal is regulatory, or the goal is all the way up here in the top part of our brain, so to speak, in the rational part. So I want us to acknowledge that we can use this framework to think about lots of different goals, those that are rational and those that might be regulatory or relational. So I want us now to take a space here and take a little bit of time. I'm going to put on a song. I'm going to introduce another tool, and I'm going to invite you to reflect on these two questions. So I'm going to show you the questions right now, and then I'm going to introduce the tool in the chat and ask you to open this up in your web browser. So I want us to start with a vision for why we're gathered together today. And the first question I want you to think about and contemplate is, why do you want to learn trauma-informed care? What is motivating you? And the second question I want you to explore is, what will it look like when you or your organization is trauma-informed? So now allow me to stop this share. And I'm going to open up, Marlena is going to drop in a link in the chat to this here, and I can do it as well. Let me drop this into the chat. There it is. So I'm dropping into the chat a link to and this works best if you're opening it. Apparently it doesn't like Internet Explorer. So if you have Google Chrome, Firefox, something other than Internet Explorer as a web browser, they may have fixed that, but previously I'd had participants say that they couldn't get it to work. If you're using your phone, turn your phone sideways and it works best. So click on that link if you can, and it should open up something like this. And this works exactly as if we were gathered in a physical space together and I had Post-it notes on your table and I asked you to write down your thoughts on a Post-it note. That's what I'm asking you to do for the next 2 minutes. And what you're going to do is, as you think about what's motivating you, you can go ahead and click this little gray box right here, this plus button, and you can type right in there and you have the opportunity to add in what's motivating you. Why do you want to learn trauma-informed care? It looks like some people are already starting to see how to do this. So you just go ahead and click the plus, add in what's motivating you today, why you want to learn trauma-informed care, and what it'll look like when your organization is trauma-informed. And I'm also going to enable the voting. So if somebody else writes something that you really agree with, you're like, oh, that's what I'm thinking too. You can go ahead and click this little thumbs up button and vote yes or no for that, or not no, but you can vote yes that you like that idea. So I'm gonna put on a song here, just give us 2 minutes to regulate and have some fun. So let me stop this share. All right. Well, thank you for engaging in that. I'm loving that. I'm seeing some great information in here. And you can, if you didn't notice, over here on the right, you can sort the data differently. So you can sort by the votes, how people voted. And you can also, I forgot to mention this, but if some of these look really similar, so if you wanted to update your knowledge and skills and you think that that's close to understand and educate others, you could slide those two together and you could say yes to merge it. I'm not going to merge it because I didn't write either of those, and I just don't want to mess it up. But if you wrote them, or if you feel inspired, you can merge these ideas together to start to see where the themes are at. But I see already, just looking at the votes, that many of you are wanting to add some knowledge and skills. You're wanting to advance your ability to understand different perspectives. Your goals for your organization is to best meet the needs of the people you serve and to prevent reharming someone. This term that we'll try and introduce, this concept of sanctuary trauma, is kind of a newer idea. And it's the idea that you are going to an organization or into a relationship with the hopes of finding healing, and inadvertently, perhaps intentionally, you find harm, right? So it's a place where you were trying to find sanctuary, trying to find support, and instead you found another source of trauma or another source of harm. So I appreciate everybody being willing to lean into that and offer up those ideas. I think that this is great. And just from yes, it was Sunday best by Surfaces. Thank you, friends. I love this community. So the reason why I started that is that if we center our intention, we have better outcomes. When we start with our purpose, when we start with our goal, when we center and we have a vision, and the richer you can paint that vision for what it looks like when you're trauma informed, the better you're going to be able to maintain your motivation to continue taking the actions and the steps to accomplishing that goal. So oftentimes we think that our inability to accomplish our goal has to do with a lack of motivation. Well, the deepest, strongest source of motivation is intrinsic motivation, and that is nurtured through deep visioning. That means sitting with the idea of what it's going to look like when you actually accomplish your goal. And we're going to touch a lot more on that next time, but we are going to keep flying through this because, as I mentioned, I got way too much stuff that I want to share today, and I'm so excited to continue this journey with all of you. So this is the HOPE framework. Again, it may be flawed because all models are fundamentally wrong, but my hope is that it's useful. And now we're going to dive in deeper into this trauma-informed care framework, what St. A calls the 7 essential ingredients for trauma-informed care. And this is the high-level overview. So we're going to touch on, the first section is actually an introduction to the trauma-informed care framework itself. Why would we even want to explore trauma-informed care? Then the first ingredient is prevalence. Then we're going to talk about impact, how trauma impacts us. We're going to talk about perspective shift. The way that we think can be a powerful intervention. Regulation, then relationship, regulation, relationship, reason to be, and then caregiver capacity. So we already kind of surfaced a little bit of this. I didn't mean for the pun, but I did play the song by The Surfaces while you've answered these questions so it just worked out beautifully. But we kind of started to surface, why are you here? Why are we here? Why is this a big deal? Why are we collectively investing our energy into this education and the desire to pursue and learn this information? You know, and I think that we have lots of different reasons, and all of us might have a slightly different reason, but we need to start with those reasons. And then I also want to acknowledge that we are going to be talking about trauma. So, you know, like, there is a chance, and this is uncomfortable for me as a facilitator in a virtual space, because I don't have the luxury of being able to read all of your body clues, your nonverbals, and see how people are processing the information. My fundamental belief is that if we can create a space for us to have this conversation, that you will hopefully be able to lean in and listen to what is helpful for you. But you also need to know and be mindful of, even if you're comfortable sharing this information, you don't know how others may be hearing it. So I want us to be mindful before we start talking about trauma. If you get to a space where you are inclined, either in a small group or through the chat, to share something, I want you to be mindful that even if you're good and in a good place with your own story and you're comfortable sharing your narrative, you don't know how somebody else may be hearing that narrative right now and where they're at. So I just want us to be mindful of that, is that we want to be able to create a space where we can sit with discomfort, because we need, if we're going to learn, we have to push ourselves beyond our comfort level, because that's literally where growth happens, is when we're trying something new, when we're outside of our comfort zone. And we also need to create this sense of vulnerability where it's safe for us to be there collectively and know that we're going to do our best not to push anybody beyond where they feel a little discomfort, but not unsafe. And there's a difference, and hopefully you understand that. We're going to be talking about some of the trends when it comes to trauma-informed care. And quite frankly, you know, even 5 years ago, this was a rare conversation to be having, but it is just everywhere now. You can see the ripple effects across all these different systems in our community. And it's led the former president of the American Psychiatric Association to articulate it this way. He says that trauma is connected to mental health. So there's a relationship between trauma and mental health, similar to the relationship between smoking and cancer. If we think about that, there's a really powerful relationship between smoking and cancer. In fact, that relationship is so powerful that it has fundamentally transformed our society. In my lifetime, I went from being able to buy and purchase candy cigarettes and seeing advertisements on TV for smoking to now having laws and regulations around where you can smoke, the age of who can purchase cigarettes, location, right? The changes around smoking in our society are fundamentally because we understood this relationship between smoking and cancer. I'm excited about what the next 10, 20 years can look like when we fundamentally understand the relationship between trauma and mental health in the same way. What could our society look like when we understand those relationships in the same level? And one example of an articulation of this comes from David Brooks, and I'm just gonna read this to you quickly. David Brooks is a journalist, a really amazing journalist from the New York Times, and says, when you look over the domestic policy landscape, you see all these different people in different policy silos with different budgets: healthcare, education, crime, poverty, social mobility, labor force. But in their disjointed ways, they are all dealing with the same problem. That across vast stretches of America, economic, social, and family breakdowns are producing enormous amounts of stress and unregulated behavior, which dulls motivation, undermines self-control, and distorts lives. Maybe it's time for people in all these different fields to get together in a room and make a concerted push against the psychological barriers to success. That's why I hope you're all here today, is that we as a community are making a concerted push. We're coming together across different fields to make this concerted push. And the psychological barrier that we have to change is our own thinking. Because we're not going to accomplish different outcomes by doing the same thing that we've always done. We have to change the way that we think, because the way that we think determines the solutions that we seek. So how does this play out? Well, we're seeing amazing things. There's a lawsuit in Compton that's ongoing right now, where they're saying that essentially that if you're not addressing trauma in education, you are failing to meet educational needs the same way as if you were failing to meet special education needs for a child. So they're making that connection, saying that if you're not addressing trauma, you're missing the foundational building blocks that all education is dependent upon. And we'll see what happens with that lawsuit. The fact that it was even a lawsuit is really intriguing. The medical community is unraveling amazing things about the relationship between stress and inflammation. And we'll touch on this, and another, one of the training resources is actually a really great article from the Harvard Center on the Developing Child about the relationship between our brain and body. And it dives in deep to this relationship around stress and inflammation. Workforce, right? We're seeing incredible things like a trauma-informed care shipyard up in Vigor, Alaska, that implemented trauma-informed care because they saw the challenges that their employees were having, but they also understood the economic impact of not addressing trauma with the workforce that they had. By not addressing trauma, they had huge rates of domestic violence, substance use, workplace injury and illness. And by implementing trauma-informed care, they saw massive reductions across all of those domains. So it became an economic policy that they couldn't ignore just from a basic bottom line. Okay, so we see some of this, but what about the data? What suggests that even becoming trauma-informed has any intended impact? So this comes from the organization that actually developed this framework that we're sharing with you, Saint-A. And Saint-A is an organization that is focused on, they're a child welfare serving organization. They're focused on foster care and keeping kids safe in stable homes. So think about the ultimate goal for the clients that you work with. In child welfare, the ultimate goal is permanency. It means a kid is safe and stable in a family setting, either with a biological parent, a relative, or an adoptive parent, as soon as possible and for as long as possible. They're in this permanency setting. So for the control group, these 277 children who weren't served by families that had been involved in this trauma-informed care training, 29% of them achieved permanency. In the families where 321 kids, where they had been involved in this trauma-informed care work, 59.1, almost 60%, almost twofold the number of kids in the control group ended up achieving permanency, right? So double the amount. So think about that. This has the promise, this has the potential of doubling the impacts that you're seeking for the clients that you serve or for the students that you serve. And so what's the need in our community? Okay, so if trauma-informed care can have a powerful impact, what's the need? Where's the data on that? So this is from the Washington Behavioral Risk Factor Surveillance Survey, or known as the BRFIS. And that's a telephone survey where we call Washington State residents and we ask them about their health and social behaviors. It's a voluntary anonymous survey. Every 10 years, we collect data on 8 of the adverse childhood experiences. We don't ask about physical or emotional neglect. We ask about physical, emotional, and sexual abuse. We ask about substance use, mental health issues. We ask about incarceration, domestic violence, and parental separation or divorce. So just when we ask about 8 of those questions, here's the data that we see. We see 62% of our Washington State residents report at least one of those 8 experiences in the first 18 years of their life. 37% say that they had 3 or more of those experiences here in our community of Kitsap. I realize some of you work across the region. The average across the region is 26.5%. And here you see a little bit better data. So we do see some community variation. So the green is 11 to 21% are reporting 3 or more of those adverse childhood experiences. The red means 39 to 51% of that community is reporting 3 or more adverse childhood experiences. But there's also this dose-response relationship. So not only is this, red segment of our community experiencing 3 or more adverse childhood experiences, but we're also experiencing 6 or more. So now 12 to 22% of those same red shaded areas, 12 to 22% of the adults living in that community say that they had 6 or more of those adverse childhood experiences. And if you're serving a community where you're seeing this clustering of adversity, you may see a myriad of challenges with the families that you serve. My colleague, Christina, took this picture of me. So thanks for that, Christina. I think she does this just to dysregulate me in the middle of the slide deck. But what the intention here is to give you a moment of pause to think about what does it mean for our community that this significant percentage of adults have experienced high levels of adversity as children. What does it mean for the system that you work in if you're seeing that this number of those clients or their children have experienced significant trauma? So that leads us to this, the idea around hope. Where can we find some hope in this conversation? I'm going to show us just a quick snippet from a video. Comes from, it's called Healing Neen. Some of you may have seen this before. So I'm just going to play this a little bit. I just want you to listen to this story, and we're going to reflect on this. So.
80% of our population has been traumatized. The trauma is the underlying reason and the basis that leads to the self-medication, the drug use, and then eventually landing in jail.
This was in '94. At this point, I was home.
Apologies. The closed captions are turned on, but they're not working. I apologize there. Let me try it one more time. I'm just going to let it play. Hopefully the closed captions.
Homeless, sleeping beneath a bridge, eating out a trash can. I couldn't go in anybody's house, including my mother's. Right here I have, you can't really tell, 2 black eyes and a busted lip. Thank you for receiving us here in El Paso. My name is Tonia Kane. I was molested, I was raped, I was beaten, I was raped, and I was like, this is how it's supposed to be for me. I am nothing, I'm never gonna amount to anything, and this is how it is. And I'll stay here, I'll die just like this. And I had become comfortable with that. These 2 houses were crack houses. He brought me down here to get high with it. He said, you know, if you don't sleep in the bus stops no more. Using crack cocaine introduced me to the criminal justice system. He thought I was trying to, I guess he thought to run off, and he thought I was resisting, so when he grabbed me, he grabbed my arm and put it behind my back and threw me against the car, which cracked my nose open. My mother had a way of, when she hit you, she would hit you with a belt, and she would hold the strap of the belt so the buckles would hit you. So we often got a lot of scars from the belt buckle.
Put that bottle down.
No, you. That's why I'm leaving.
Put that goddamn bottle.
I bet you that's why.
I'm gonna whoop it.
I was beat, I was raped, I was hurt, I was beat. Okay, that's happening no more. But my children are still living. They're still walking this earth somewhere, and I know nothing about them. How do you heal from that? And she said, you do. What are you thankful for?
Mommy!
Treating my trauma totally broke that intergeneration curse. Good morning. I'm living the American dream. I'm in debt.
She now, as of yesterday, officially has become the team leader for the newly funded National Center for Trauma-Informed Care.
And I can get snakes. Why can't we keep working at it, working at it, working? Why can't we work at it ourselves? 83 arrests and 66 convictions. 3 times down here and multiple times in the county jail. They said I was gonna spend the rest of my life in jail and die. I wasn't gonna amount to anything. Not so. Not so.
So I know that her story is special. I also want to offer up that it's not unique, meaning that, you know, we work alongside an amazing leader in our community who was arrested over 35 times. has a very similar story, and he's now working to support individuals who've been incarcerated, connect to our community, and continue to find ways to flourish in our community. Right? He's part of the Welcome Home team. So I want to create this space and this idea that trauma happens, but so can and so does healing. And I thought that the last part there, right? As long as there's breath, there's hope. If we think about that framework around hope, it's a belief that tomorrow can be better than today and that you have the power to make it so. And if you are a helper and healer in our community, it's likely that you're working with somebody who is like Neen, who's had some trauma. Maybe it's not her story, but it's a story of trauma. And for them, you are a potential pathway towards them accomplishing their goal. It's our responsibility to help them see us as pathways, because if we don't do that work, they might see us as a barrier. And I can tell you from 10 years working in child welfare that people are super creative and they will find ways around barriers. You know, I worked with a mom who was buying urine online in order to pass drug tests because we'd never had a conversation about her goal. But when we had that conversation about her goal, her behavior changed, and her behavior changed because she saw me then as a pathway towards achieving her goal instead of a barrier that was getting in the way, right? So, but it was on me about helping her. And that meant we had to have a conversation about what was her vision for what was she trying to accomplish. And I'll tell that story another time as well. So I'm going to keep us moving here. So hopefully you feel a little bit more excited about, all right, I came today because I wanted to learn trauma-informed care. I'm seeing that there's a powerful impact that it can have. If we learn this stuff together, we can really have the intended impact. So what we're going to touch on today, we're going to hit the introductory concepts. We're going to touch on the first, the prevalence of trauma. I want us to think about some of these learning objectives. We're going to accomplish this over the course of the full training series together. We're going to look and learn about the frequency of adverse experiences in the lives of people, have a better understanding of the social, emotional, psychological, or physiological and developmental effects of trauma in people, families, and whole communities, understand and respond to behavior from a trauma-informed perspective, understand the value of developmentally informed activities, understand techniques that can enhance relational well-being. So learn how we can develop stronger, better therapeutic relationships. Understand ways to inspire a sense of purpose, belonging, safety, and hope. Understand techniques that can enhance the capacity to care, our own ability to continue doing this incredibly hard work, and the connection between our capacity and the outcomes of the people that we serve. Be motivated to start putting these things together in our actual practice in powerful, real ways, and recognize historical and intergenerational trauma and equity are central to understanding trauma. We like to think about the words of the RISE Center, an amazing organization in California that says, it's not trauma informed if it's not racially just. So one of the documents, and I'm going to ask Marlena to drop in the chat, I built a resource document that has links to everything that we're sharing today. One of those links should be this working definitions document that you'll have, because we want to develop a shared language. And this is a living document, meaning as we get better and have more of these conversations, we as a community may define these things differently. So this document is constantly being improved. So when we use the frame around trauma-informed care, I want us to think about kind of 3 different domains of trauma-informed care. One domain of trauma-informed care is the actual physical environment that we're in. There are things that we can do to make the physical environment as pleasing to humans as possible. right? Like you can use the word trauma-informed, or you can look at the work of universal human design. Is the environment built with the needs of all humans in mind, or is the environment designed for a certain type of human? What I mean by that is that as a white male who's able-bodied, I walk into literally every built environment that was designed for my needs. There is always adequate restrooms for me. There is usually, I'm not concerned about if there's a flight of stairs or not up to the door, right? Because my able-bodied status, most environments have been built for that in mind. But there may be individuals who the environment was never built to consider their needs. If you have an individual who's on the autism spectrum, they may have different sensory needs, and your physical environment may be just overwhelming for them in the way that you've constructed either the light or the sound or the flow of humans through the space. And universal human design focuses on how do we construct the physical environment so that all people can flourish. Care is really what this whole 7 ingredients is about. So I'm going to come back to that. Treatment is about what happens with a clinician that's working with somebody who's had significant trauma and they're trying to help them heal, right? So there's trauma-informed care that happens in that clinical relationship between a psychiatrist, a psychologist, or a therapist in our community, where they're implementing a specific trauma-informed neuroscience-based therapeutic technique like clinical problem solving, like evidence-based models like trauma-focused cognitive behavior therapy, CBT, TFCBT, clinical rescripting, right? We're not going to get to treatment other than to just know that there are some humans that you're working with that are going to need treatment, and you should try and be the best connoisseur of treatment in our community, meaning advocating for that there are licensed people in our community that can provide different modalities that meet your client's needs. Our focus for this conversation is really going to be about care. It's about the 7 essential ingredients. It's about those informal supports. It's about how each and every one of us are helpers and healers in our community, and there are little things that each and every one of us can do when we have peer support, when we have coaching and practice, and we have the support of our administration. We can start to do things with the individuals that we work with that have a powerful impact, especially if we're also thinking about and considering trying to make slight, subtle changes to the environment itself. An example that I'll bring forward is that in my work in child welfare, one of the interview rooms that I interviewed parents in had the layout of the room put their back to the door, right? I didn't think anything of it. Our social workers didn't want to go into the interview room and have their back to the door. And so they had organized the room in this way. Well, if you're an individual who's experienced a lot of trauma and you're coming in to have a conversation about physical abuse and neglect, you may not be feeling super safe and secure anyhow. You're going to talk to somebody in a position of power, and suddenly you're sitting in a seat with your back and your whole presence to the door. You don't know what's going on behind you. So we physically just pivoted the desk so that neither the interviewer, the social worker, nor the parent that was being interviewed had to sit in that environment with their back to the door. A little subtle tweak, but could be really powerful for an individual who's experienced lots of trauma, and that environment itself is not constructed in a way that helps them. So the trauma definition. So I want us to acknowledge that there are lots of things that are traumatic, but just because it's traumatic doesn't mean that it results in a trauma response. And that's the way that we're going to use this word, trauma response. So let's use an example of a car accident, right? This is an event that threatens to harm you or somebody that you love, harms your physical or emotional integrity. A car accident can be a very frightening, very traumatic incident. And maybe in the moment you feel totally overwhelmed. Right? That third component is the one that we need to be mindful of. Adaptions create significant difficulty in functioning. Okay, so you've experienced a car accident, you felt overwhelmed, you get medical care, you take some time off of work, you're getting ready to go back to work, you go and sit in the car the first day and you just can't leave your driveway. Nope, I'm not going to do it. And then the next day, nope, I'm not going to do it. And pretty soon you got a coworker who's coming by to pick you up and they're doing that as often as they can, but it's becoming really challenging, right? Maybe what has happened is this trauma response. So that car accident was traumatic. It overwhelmed you to such a degree, and then your behavior adapted to such an extent that it's actually impacting your daily life. Like you can't get to work on time because you can't get in the car. You're now trying to take public transit. You're trying to find all other pathways because you're frightful of getting back in the car and what could happen, right? That I'm using that as an example, but most individuals that have been in a car accident, that doesn't lead to those significant adaptations that result in difficulty in functioning, right? Maybe that first day in the car, they're a little bit more cautious, they're a little bit more, but they keep doing it and they're able to, and they have enough support that they're able to, quote, bounce back, as we talk about. So when we use the word trauma, when we're thinking about this, another way to think about it is stressful versus toxic stress. Toxic stress is the amount of stress that overwhelms your ability to cope. So I like to think about it like a teeter-totter. We can handle a lot of stress if we have enough things to balance us out. And it doesn't impact that, the fulcrum's the middle part of your teeter-totter, right? It doesn't impact that fulcrum, meaning it doesn't push it one way or the other unless things are totally out of balance. So if you've got enough stress, but you've got enough support, enough things that help you respond, it probably doesn't relate in significant adaptations to functioning. So, but alternatively, you may experience sexual abuse. And even though you got a loving grandma and a great relationship with your teacher, that continuous exposure to sexual abuse and nobody knowing what's going on with you and not feeling like it's safe for you to share what's going on, that can lead to adaptive changes in functioning. An example of that was a young mom that I was working with. She was sexually abused as a child and had become a therapist and had found ways to cope. And throughout most of her adult life and even into her romantic relationships, she said that it really didn't impact her much. And then her daughter was born and she was changing her daughter's diaper and she was wiping her daughter to clean her up. And her daughter had kind of what I would say a neurobiological, a normal response to somebody touching her genitals. She responded, she giggled. This mom who'd had significant sexual abuse history, it triggered her. In the moment, it flooded her with all of these memories, and she got to thinking that maybe her daughter enjoyed it when she was wiping her and touching her. This mom, this progressed, she kept ruminating, which means you just keep thinking about it. You can't stop thinking about it. So then she said she couldn't change her daughter's diaper anymore. She said, no, I can't wipe my daughter because my daughter's, she enjoys it when I touch her. There's something going on there. So suddenly her partner has to change every diaper. Now, if you can imagine a newborn, a newlywed couple, they have their first child. Imagine the stress that adaptation brings on their relationship. At first, he doesn't even notice that she's just kind of handing off the infant every time that her baby daughter needs a diaper change. But pretty soon, his paternity leave ends, he's got to go back to work. And he realizes that his caregiver is unable to change their daughter's diaper, right? This adaptation, her way of responding to this stressful thing, resulted in significant difficulty in functioning and resulted in, significant challenges in their relationship. So I'm hopefully helping you see the difference between something that's traumatic and something resulting in that trauma response. That trauma response can be a cognitive thing, like the examples that I shared with you, or it can be a neurobiological thing where your body adapts to the trauma in a way that you may not even be mindful of. And I think that this is something that we're just continuing to think about. And that article that I mentioned earlier about the relationship between our bodies and our brains and the relationship around toxic stress and how it leads to inflammation and can lead to things like cardiovascular disease in adulthood. That might be a difficulty in functioning that shows up that you don't even really notice could be associated with trauma. So this is the idea that I'm trying to spell out here, is that stress is inevitable. We all experience stress in our lives. There is a type of stress that is, as we were using the language last time, that becomes toxic. So if you look at this down the left-hand side, stress that is unpredictable, extreme, and prolonged can lead to what we would call sensitization or neurological vulnerability. Sensitization means essentially that your brain is adapted to your trauma, developing different neural networks in a way that the next stressful event produces an outsized response from you. You've become sensitized to stress. Your baseline for stress is up here because you've just been continuously inundated and your stress activation system is constantly on red alert. Unpredictable, extreme, prolonged. Think about the case of physical abuse for a child. You know, and in a household where there's domestic violence, there's physical abuse, and there's substance use. When the caregiver is sober, maybe there's very little violence. And then when the caregiver gets intoxicated, sometimes there's yelling. Sometimes there's physical violence and assault. And this becomes a pressure cooker of unpredictable experiences. That individual, that child growing up in that environment is constantly on red alert because they don't know if tonight it's going to be a mean word or tonight it's going to be a belt buckle. And that extreme nature of not knowing what's going to happen and the fact that it ever gets to the point where you feel physically unsafe and that it's prolonged. There's no respite from this. You're constantly living in that environment, leads to this neurological sensitization. On the other side, let's use the example of playing a board game with your young child. I've got a 9-year-old and a 4-year-old, and it's painful to play the game by the rules, but this is why we do it, right? I need to give my kids safe, predictable, moderate, and controlled exposure to stress so that they can build neurological tolerance and resilience. Because stress is inevitable, it's a part of life. By playing that board game by the rules, there's predictability to it. The way that we moderate stress, I believe, is through relationship. And the way that you give it a sense of control is that you can play by the rules. You have choices each and every round of the game. So that you feel like there's a sense of control, there's a sense of power, there's a sense of autonomy. When we have the perspective that our actions can influence the outcome, when we have relationships that help to moderate the stress, and when there's a sense that there is a boundary around how long this is going to happen or what the extent of this looks like, that leads to neurological tolerance and resilience. I also think about this whole pandemic in these two domains, and that the pandemic has very much the potential of being an unpredictable, extreme, prolonged experience. But I also want to state the case for hope that we as helpers and healers in our community and leaders, we can take that stress and make it predictable. Saying, you know what? We don't know when this vaccine is going to roll out to all of our community, but for the next 6 months at least, we are all going to mask up, we're going to maintain our distance, and when it's our time to get vaccinated, we're going to get vaccinated. Boom, we've set some sort of predictable pattern around this. This is at least for the next 6 months. And even bad news with an expectation is better than the unknown. We function better even with a bad, honest assessment of the situation than with the unknown or the blind belief that it'll just get better magically, right? Like that doesn't actually, humans function better even with disconcerting news when you're giving it like that. Okay, this is how long it's going to be for the next 6 months, or this is exactly what we're going to do for the next 6 months, and we'll reevaluate then. It's moderate, meaning that we can maintain social distance, but still try and foster strong relationships, because relationships are how we're going to navigate this, and giving people a sense of control, a sense of choice in whatever ways that you can, in as many opportunities you can. As an employer, this may mean giving my employees different opportunities to decide how they want to show up at work, what they want to choose, how they want to make decisions. Creating as many opportunities for choice as possible helps people feel like they have control over the stress that they don't have control over, right? So I've covered a lot there. I'm going to pause before we dive into this slide. And I just want to see in the chat, is there any question that we may have about this idea of stress, the two types of stress, either toxic stress or tolerable stress, or any questions about the trauma definition before we move forward? You can either throw your question in the chat or take yourself off mute. Thank you. So the question is there a difference between toxic stress and trauma? Are they the same? So we are trying to use these two words interchangeably. Trauma response, which involves all three of those components, and toxic stress. So when you're saying trauma, you mean all three of these, something that's potentially traumatic, that it overwhelms your system, it knocks you out of balance, and it leads to adaptive functioning, changes in functioning that are difficult for you to manage. If those are the three components, then the way that you're using the word trauma is the same as the way that we're thinking about toxic stress. What we want to get our heads around is the idea that not everything that's traumatic results in a trauma response. You can be in a car accident that doesn't result in trauma response. You can even experience physical abuse that doesn't result in toxic stress. And I don't want to minimize the experiences of anybody who's experienced physical abuse, but I also want to be mindful to not take away the power of our aunties, grandmas, teachers, amazing caregivers who, in spite of adversity, help to make sure that that adversity doesn't powerfully impact our brains and bodies. And I know that this is true, not only because the science suggests it, but because I've had so many conversations with families in our community where I've done, my last role in child welfare was facilitating family meetings. And the number of times where I facilitated family meetings and mom is there, she's involved in a violent relationship, has active substance use issues, has mental health issues, and she's in a position where she's unable to keep her child safe. And auntie, who grew up in the exact same household, is sitting in the seat next to her, is a registered nurse in our community, and is going to be placement for the child. And every single time, if we had enough time for the conversation, every single time I would hear auntie say something like, man, we had a hard childhood, things weren't good with mom and dad, or whatever the case was. I had so-and-so. I had the neighbor, I had a teacher, my coach, my 4-H instructor. Every single time I heard them articulate to me the power that we as a community have to balance out that toxic stress if we interact. The idea that you can heal from toxic stress. It's a wound that may heal but scars. That's interesting, yeah. I also like this idea of invisible scars, right? The idea that a lot of the mental health challenges and substance use that we see in our community are the results of wounds that we can't see because they happen to be to an organ that is trapped inside of our skull. So if that wound happened, right, a way of thinking about it is that trauma is actually impacting our brains. And that means that there's a wound to some of those neurons, some of the neural connections in our brain, but we may not be thinking about it and seeing it. And if we're not, how does that influence our caregiving, right? So I appreciate that, Jessica. I think that's a great statement to consider. Any other questions about the types of stress or about trauma response? All right, hearing none, we're going to continue on having fun. So this is an overwhelming slide on purpose. What this is an actual diagnosis of a 13-year-old child that the lead trainer who developed this curriculum saw and treated. So this is the, if you're familiar with the Access 1 and Access 2, the DSM, the diagnostic manual that clinicians use, these are all the different diagnostic labels that they attach to this 13-year-old, saying that he had all of these different mental health issues, and he was on all of these different medications, and they'd also tried 39 other medications. He says in 30 years of practice, he was in one of the top 10 most challenging individuals, but he was also with some of the most incredible adoptive parents that were offering him balancing out that teeter-totter as much as they could, right? And so my whole purpose here is this conversation is to create a space in a sense that our actions matter. The way that we as a society respond to individuals who have experienced toxic stress can either add to that stress or help them find a place for healing. And one of the sources of stress that we need to be very mindful of is historical and intergenerational trauma. Right? In our own community, one of our dear partners in Kitsap Strong, one of the founders of Kitsap Strong, her name's Robin Saigo. She's on the tribal council with Suquamish Tribe. She's a licensed social worker, has been working in our community for many years, developed the Healing of the Canoe, which is an incredible youth substance use prevention module. If you haven't seen it, I highly recommend it. Marlena, remind me, we'll attach it to the resource document. So the Healing of the Canoe. But she shares that, you know, in her own family, her grandparents were removed from the community of Suquamish, taken to boarding schools, forced to learn English, brutalized for speaking their own language. Right? This is in her own family's immediate, her grandma experienced this. So this isn't ancient history, my friends. This is very real and very present right now in the moment. And the legacy of these things, one of those legacies, unfortunately, is also slavery. And if you haven't seen it, we don't have time for it, but you, nope. Do not start the next video. If you haven't seen it yet, the 1619 Project is incredibly powerful. It's about the 400 years of history of slavery in the United States of America. And they have podcasts, they have amazing articles. It's all a great resource. We got a link to it in the resource document. But if you want to understand healthcare, education, any of these services in the United States of America, you have to first understand our history with slavery. And it's a powerful component to this narrative. So I'm going to open up another video. Again, I've got the closed captions on. My hope is that it pops up. I don't know why it didn't work last time. I'm hopeful that it works this time. So we're going to, LaDonna, I can see you in my screen. So if you'll give me a thumbs up when I press play, if you can hear it, that would be fabulous. Thank you.
What matters in life is not what happens to you, but what you remember and how you remember it.
My dad said when they were growing up, they said, we used to play cowboys and Indians. And he started telling me this story. And we used to fight over, nobody wanted to be the Indian. And he said, I didn't think about that. We'd all play, and I'd always suck it up, and I'd be the Indian. But how ironic is it for a bunch of Indian children to be playing cowboys and Indians, and nobody wants to be the Indian? The introduction of a destruction of culture and loss of what is good. And I asked my dad, well, why didn't anybody want to be the Indian? And I thought I knew the answer. He said, because everybody knows the Indian dies. And that already in his generation, as strong as he was, he received a message as a young child. I received the same message, that it was not good to be Indian.
Slavery, colonization, forced relocation, and other historically traumatic events in generations past have lingering and profound consequences today. But what is historical trauma?
Historical trauma has to do with collective, cumulative emotional wounding over and across generations that results from massive cataclysmic events. These are events that don't just target an individual, but they target a whole collective community. Things like forced relocation from traditional homelands, like the Trail of Tears, like my ancestors went through. But the process that our communities talk a lot about is that the trauma is held personally, and can be transmitted over generations. So even family members who have not had a direct experience of the trauma itself can feel the effects of that event generations later.
Does historical trauma only affect certain groups of people?
What really helps me to help people understand the notion of historical trauma is that it's actually a phenomenon that lots of communities, indigenous communities, or people all over the world have sort of kind of struggled with. It's not something that specifically is only owned by tribal people or indigenous people. It gets articulated all over the world.
Historical trauma is widespread, affecting many communities across the globe.
Observation has, from the empirical side, started with work on the Holocaust survivors. And there's a lot of work on intergenerational transmission of trauma. And it's moved into also looking at Japanese internment survivors, Armenian survivors, descendants of their Holocaust, and so forth. So there's been some more empirical work in this area. And you can imagine trying to track trauma over generations and trying to tease out what is the impact over generations on this child, combined with whatever traumatic events they've gone through in their childhood and in their lifetime.
Historical trauma is passed on across generations.
I say to you, acknowledgement is due my grandfather, Pop. He never told us the stories of why he did certain things. He never shared with us why he never cried, for example. He never shared with us why he walked out the door when my grandmother cried. Why he turned his back when she cried. Of course we thought he turned his back because he didn't care, of course. But he turned his back, as I look back now, because the pain has no words. I still have the images of him dealing with the limitations that he was up against. I can only imagine the pain. But what I do know is that it didn't go away. It came inside into those of us who followed him.
No one ever talks about the moment you found out that you were white, or the moment you found out that you were black. That's a profound revelation. The minute you find that out, something happens. You have to renegotiate everything, and that's a profound psychological moment.
I saw a water fountain that said white in color. My family was 7 kids by then. We drank a lot of Kool-Aid. So colored water, that was in my cognitive schema. So I go toward this colored water fountain. And while I'm there, just before I get there, there's a little white girl who saw that same colored water fountain, and she was just about to turn the sprocket when her mother came and grabbed her by the arm. And she said, "You cannot drink from that colored water fountain." And she said, "But I want the colored water! I want the colored water! Oh, I want the colored water!" So I knew it must be good. So I run to the colored water fountain, looking for my mom, making sure she won't stop me from drinking. And I turned the water fountain, and it was clear, just like at home. That day, that trauma, I remember to this moment.
For African American communities, historical identity and understanding is inextricably tied to the reality of enslavement.
It ties us to enslavement with what an awful terror, 400 years of trauma we experienced. And for us, we talk about it as being utter cultural erasure.
All right, so I wanted to acknowledge again that just create the opportunity for us to think about the myriad sources of trauma. Some of those being our own lived experiences in our own household, which is what the adverse childhood experiences is trying to understand. Some of those being the experiences of our ancestors. Some of those being the experiences of the community, our collective experiences on this land. And that I think Dr. Anda, the original researcher from the Adverse Childhood Experiences story, says that trauma that happens in the context of relationship needs to be healed in the context of relationship, right? So it's through relationships that you're going to heal trauma that happens in the context of a relationship. Similarly, I'd like us to offer up the idea that cultural trauma needs to be healed through cultural ways. And that in order to heal trauma, we have to acknowledge that it even occurred. So I'm actually inspired as I watch our community grappling with 400 years of slavery and colonization and all of the things in the protests that occurred last year. Because I'm hopeful that it means that our community is grappling with these things. I'm also hopeful that it means that we are willing to explore some community solutions and some community pathways to having these conversations, acknowledging that the trauma occurred and exploring ways to heal it. One way that this showed up, just quickly, I want to offer up this as an example. In Germany, they have these little things, and I can't remember the pronunciation of the German word, but they translate to stumbling stones. And there are little copper plaques on the bricks throughout Germany with the names of Jewish residents, literally on the street, on the corner, outside of the households and the places where they were taken from and taken to the internment camps of Auschwitz and others. So these little plaques on the ground, these stumbling stones, signifiers of a collective trauma and one acknowledgement, one way of acknowledging that. What would it look like if we were to navigate our community through our shared spaces and we saw the historical reminders of the individuals who were removed from those lands at one point, right? The Japanese internment camp on Bainbridge Island, the Native Americans who were removed from their lands throughout these territories. What would it mean for our community to have that sort of reckoning and acknowledgement that this had occurred? This is also why I'm so inspired by the work of the Welcome Home movement with Port Gamble S'Klallam tribe and by the Suquamish tribe's work around the healing of the canoe and the language immersion that they're doing with their early learning center, right? Because they're focused on their native language and teaching the native language to their children, because they acknowledge that this is a pathway to healing by a reconnection with our culture. And I also want to acknowledge for all of us that may identify as white, that we also have culture and that many of us might have given up our specific cultural origins in order to become white when we came to America. What I mean by that is that my family stopped being Norwegian, stopped being Irish in order to become white. What does that mean? And how does that play out And how do we just continue to have these conversations? Because white supremacy doesn't impact just one of us, it impacts our whole society, impacting health outcomes for every single one of us. So I'm going to continue on here. We could devote way more than the rest of this training to sources of intergenerational and historical trauma, but I wanted to just create the lens and the understanding that it is something that we need to make room for in this conversation. So I've got a little bit of time left to touch on the prevalence of trauma. That's okay, because we can pick up this part as we move together on Thursday. So the prevalence, how often does it happen? Who does it happen to? How does it compare? What about for the population that you serve, the humans that you're trying to work alongside, and the humans that you're trying to care for? How many of them, what percentage of them have experienced some sort of trauma? So in your resource documents, you will have a link to the ACEs questionnaire. And if you don't, I apologize, we'll send it to you. But I'm not going to have us dive into it right now. I'm just going to remind you of the 10 adverse childhood experiences: physical, sexual, and emotional abuse, physical and emotional neglect. So 5 categories of child abuse and neglect, and then 5 categories of what the researchers called household dysfunction. Growing up in a household where there's substance use, where there's mental health issues, where there's domestic violence, where a caregiver is incarcerated, or there's separation, divorce of a caregiver. So when we look at those different things, and these are the 10 things listed out, and the percentage of individuals from the original study, 17,000 predominantly white, wealthy, highly educated individuals, in that Kaiser study, that's the percentage of them that identified each one of those categories of abuse. Then we're looking in the middle at the Wisconsin data, and I showed you earlier our Washington State data. We lump it together a little bit differently, and that's the thing that's the most critical about. And then, that last column is kids involved in foster care, teens involved in foster care, independent living services, ILS. Independent living services is a service for teenagers in child welfare. So here's another way of thinking about this. We're looking at the percentage of individuals in that first study. 33% had 0 adverse childhood experiences, compared to 43% of the Wisconsin state average, which is where this curriculum comes from, compared to 0%. So compared to less than 40% in Washington State. So we are somewhere in between the two there. And then you look at how many of our kids in foster care, this is the reason why I kept this slide in here. I want you to see that youth in foster care, 65% of them have 4 or more adverse childhood experiences. Okay. Another way of looking at this is, now we're looking at the urban ACE study. This was done in Philadelphia. So you're looking at, they also differentiated across African Americans and white members in Philadelphia. And so you see this clustering of these different experiences, like witnessing violence in your neighborhood, or discrimination based on race, or adverse neighborhood experiences. Right? And I want to paint the picture here that exposure to more community violence being another source of stress is deeply connected to our nation's relationship with slavery and the economic policies like redlining that have influenced the formation of built neighborhoods. We have clustered poverty. We have forced individuals, African-American individuals, into neighborhoods with high concentrations of poverty, especially in urban centers, as there was redlining practices that did not allow them to purchase homes in certain areas throughout the city. So adverse childhood experiences. What I want us to understand about this is that there's some certain things that it can tell us, there's certain things that it cannot. So when we give the ACEs screening tool to somebody, it can tell us about exposure to trauma, at least those 10 types of trauma. It can tell us about trauma that happened in their household in the context of their caregiving relationship. because the way that the questions are actually asked is what happened in the first 18 years of life, and it's asking about your caregivers and what was going on. It's retrospective, so by definition, you're asking people to think back about their childhood. And we do know that there's this powerful relationship. Literally, more than 40 different health outcomes have showed this relationship where that as the individual's health, as their ACE score increases, so does the likelihood of health and social challenges across the lifespan. This is at a population level, we see this pattern emerge. But we also know that adverse childhood experiences is very, very limited. When we give them that screening tool, when you look at that screening tool, it's not telling you about the frequency of adversity. You know, if you said yes to physical abuse, you might have experienced physical abuse one time in your childhood. We don't know how intense that physical abuse was. We don't know the type of support that you had during that incident, and we don't know the age you were when that occurred. You could have had one really intense experience of physical abuse when you were 16 years old. You had tons of support. You went and lived with your grandma. That's very different than if you grew up in a household where you experienced physical abuse daily. It was consistent. Every single day you were beaten with a belt buckle. You had very little support. You didn't go to school. You were homeschooled. None of your neighbors knew what was going on. And it happened from 6 months old because you cried too loud all the way through your childhood. Both individuals would check the same box as experiencing physical abuse on that ACEs screening tool. And they have very different potential implications from that experience. We also don't know about community other events that are happening outside of your household context or pre-existing factors. We're not getting anything about your historical experiences of your family from that 10 screening, ACEs screening tool. Okay? But here's what we do know, and this is why it's so important, and this is why it has value at a population health level. We know that the cost of adverse childhood experiences is massive. The cost of our current community solution, our current community response to people who've experienced trauma and adapted to trauma is at the tune of 124, you're seeing this number here, 124 to, the estimate is a little high here, 124 to $500 billion is the estimated cost over the lifetime of 1 year's group of kids and their adverse childhood experiences. A big part of this cost is associated with lost productivity because individuals with a high ACE score tend to die early and have higher health complications. And so that's where these estimates come from. You actually see the article references down at the bottom there. I saw something pop up in the chat. I'm gonna try and open my chat, but of course it won't let me. So I'm gonna pause just in case it's a question that, oh, there it is. Educational and medical trauma from being misdiagnosed, overly medicated. Beautiful, Jody, thank you. Jody's articulating this concept very powerfully that I tried to introduce earlier, this idea of sanctuary trauma. This idea that you may have adapted to trauma, you have behavior patterns that keep you safe, and then you enter into a setting that is supposed to be, quote, safe and is supposed to be healing for you, like your kindergarten classroom. And instead of finding safety and security, your behaviors are met with frustration, anger, you're sent home, you get disciplined disproportionately, and that individual is not on a trajectory towards healing, they're on a trajectory towards isolation. Right? So how does this compare, right? So I want us to think about this right now. Another way to appreciate how important and prevalent adverse childhood experiences is to stack it up against other things that we're aware of around the risk. So you can use the chat if you want to. Anybody have an idea about the national prevalence of autism? How prevalent is autism? Meaning what percentage of individuals in our community experience autism Anybody have a guess? It's okay. No, I appreciate I love the discussion in the chat. And I know that there's challenges around diagnosis. With all of that in mind, what percentage of individuals in our community do you think? 1 in 10, Tammy, thank you. So about 1% of the population may be on the autism spectrum disorder. And Tammy's really, go ahead. I don't know if somebody was trying to jump in there. Tammy's spot on. The estimate is anywhere from 1.5% to 1% of individuals on the autism spectrum disorder. What about childhood obesity? What percentage of our community do you think is struggling with childhood obesity? %, 10%. Anybody willing to go higher than 10%? 20%? We're really close, somewhere in between those two. The estimate, the national average or estimate is 17% of children are struggling with childhood obesity. I mentioned these two, right? We bring these two up because there's been lots of conversation around autism in our community. Maybe not enough, but there has been some conversations. There's definitely been a focus and energy around childhood obesity. In fact, we've had presidents and first spouses champion action, collective action around obesity and doing something around this. Now, I want you to acknowledge and think about that even a conservative estimate is that 25% of individuals are exposed to toxic stress. That's the prevalence rate of toxic stress is 25%. Again, we as a community need to be thinking about how do we intervene in the way that we might if we saw and truly understood how prevalent this is. So I'm gonna ask you to reflect for just a minute here or so. I want you to think about the population that you started off this conversation with, the work that you're thinking about, the work that you do in our community, the humans that you serve. What percentage of those do you think have experienced toxic stress? And let's do this in two ways. I want you first to think about what percentage of the humans that you work with have experienced something that's traumatic. So what percentage have experienced something traumatic? And then the second part of this is what percentage of those individuals do you think meet the trauma response or toxic stress definition? Meaning, what percentage of the humans that you serve, students, clients, patients that you work with have experienced something traumatic? And then what percentage have experienced something traumatic that overwhelmed them and resulted in significant adaptations? So you can put the two in the same line. 80, 60, 100, 100 from Christina. $175, 180, 190. And I'm hopeful. I know that we're pulling in people across many different spheres here today. I'm really hopeful that we're not dealing with 100. But you might be spot on, right? If you're working in our medical community, if you're providing behavioral health services, so chemical dependency and substance use treatment, you're probably spot on that 100% of the individuals you're working with experience something traumatic or close to that. and maybe 90% of them have the toxic stress. I want to create the opportunity that there's always going to be outliers, right? Every model is wrong. Some are useful. Okay, so there's always the potential that you're working with somebody that hasn't experienced something traumatic, or maybe they don't have toxic stress. But what would our society, what would our service response look like if our assumption was more towards what most of you are articulating? What if our whole system was built on an assumption that most people have experienced something traumatic, and maybe the majority of them are struggling with this trauma response? How would we organize our services, our resources differently if that's the way that we were thinking about it? So I'm going to invite you all to now, I didn't prep you well enough for this, but I want to invite you to join into a small group conversation. I'm going to ask Marlena to send us into groups of like 3 or 4. And I just want you to process this for a moment. What would it look like if this is the data that's true in our community? What actions might we be inspired to take? What would we do if this is the prevalence of traumatic experiences and this is the prevalence of trauma response in our community? What would we be inspired to do as a community?
Are you ready?
Yeah, that'll work. And we'll go ahead and pause the recording and just give some people, let's give them at least, let's go 6 minutes in your groups. I just want you to chat with somebody else. And feel free to go on a tangent. If you want to talk about something else that we've talked about, do that too. But I really want you to think about this idea around, percentage of the clients that you serve that experience something traumatic compared to the percentage that have developed or have trauma response. And what does that mean for our collective work? Go ahead. Thank you, Marlena. Into that. So I'd love if there's a group or two that's willing to share a highlight from their conversation, that is willing to take themselves off mute and share a little something that they discussed as they were thinking about the information we've covered so far.
I think that more people would invest in community mental health and just invest in mental health in general if they knew that people were dealing with, toxic trauma and just toxic stress, and how debilitating it can be for people to actually move their bodies and do stuff and, go on with life. If more people knew the importance of it and treating it more like a public health crisis and not just physical health, but mental health as well. And putting those two together and finding the importance and the resources for both of them that meets every social, economic status and group of people, and make it really attainable for everyone to receive the type of help that they deserve and that they need to be functioning humans and children in society. Give them that chance.
Thank you so much for that. Yeah, right. Like, what would our community investment be like if we understand it, if we really understood the prevalence and how it's already impacting our community? We like to talk about the cost of the status quo, right? So the way that our community is responding is costing us pretty significantly. What's that cost of the status quo look like? Other groups that want to share a highlight from their conversation.
We talked about, excuse me, collaborative and cooperative wraparound services, treating every individual individually, but yet also recognizing that that they're part of the community and working as a community. And I work for a tribe, and so we're the tribe. I keep trying to put myself into the tribe, but I'm not. But the tribe is creating more, I guess, culturally aware and trauma aware services that that work together in all departments of the tribe. So it doesn't matter if you're a counselor or one of the council or whatever, everybody is working to help all individual people. And yeah, so we did talk about that as a community and as a kind of a goal, is that each person is acknowledged for their individual history, but treated together as a community, if that makes sense.
Yeah, thank you, Heidi. Appreciate that. Jennifer, you're willing to share as well if you'd like to come off mute?
Yeah, I thought it was a good discussion. There was one person in our chat, Ariel, who is from Spokane, and she was saying how she was like, I wish we could just have like real actual counselors, you know, providing coping skills and mental health and everything in the school system. And so I was telling her how, you know, when I started at Peninsula years ago, our local schools were completely against school-based health. And then we opened one. And after year one, we opened 4. I think we're up to 6 now, and we're going to open another one soon. And so it's like, now the schools are like, come, please come. And I was mentioning that we do medical, but we also do mental health and substance use treatment in pretty much all of our school-based centers. And it's just been a huge game changer. Granted, 2020 wasn't awesome. You know, we did a lot of virtual care as much as we could, but it's still not the same volume as we saw when we were actually in the schools. But we still feel like it's been the right place to be and to provide those services. You know, so I highly encourage that. And part of that, I would say, you know, shout out to Cody and Kitsap Strong. You know, they were part of the group that sort of helped bring together the schools and us and get the schools more comfortable with the concept. So. Well,
thank you for that, Jennifer. And again, I appreciate your leadership there at Peninsula. And I think that it's this, when we collectively have this shared understanding, then we start to problem solve differently. When we understand the prevalence of trauma, we may start to explore different solutions. I wanted to share with you some data points just to kind of wrap this up. Was the estimate for these two numbers, the two things that I asked you about, the national estimate for the general population in the United States of America is that 70 to 90% have experienced something traumatic. 70 to 90% have experienced something traumatic. But when we talk about trauma response, and again, if you think about that story I shared with you about the mom who'd experienced sexual abuse as a child, and then as an adult was unable to change her baby's diaper. Now that's a pretty profound trauma response, right? Thankfully, the national estimate is only 10 to 20% of the general population has trauma response. So again, 70 to 90% have experienced something traumatic. Only 10 to 20% have trauma response. I'm not trying to invalidate what you guys shared in the chat, because if you think about behavioral health care in our community, you are hopefully working with no more than 20% of our population. So if you're saying 100% of the people I work with, 100%, right? You may be working in one of those spaces, housing, right? Substance use treatment, mental health care. You may be working in one of those spaces where you're only serving, thankfully, around 20% of our population. That 20% just happens to be those who have significant trauma response, and the other systems aren't responding in a way that can help them find healing without needing the level of care that you're able to provide. So in our last 5 minutes, I want to end with this, this poem to center some of the incredible work at Port Gamble-Sklallam Tribe and the reentry work, because it's a fabulous way for us to end our first session, hopefully feeling a sense of hope as we continue learning this stuff together. So this is in your resource link. This is a poem, and we've got the author's permission to share this poem with you all. And this comes from a video, a longer video that we don't have time for, that highlights the incredible work at the reentry program in Port Gamble S'Klallam. I want you to know that since they made this video, some data points have changed. They actually achieved over 80% recidivism rate reduction in the clients that they work with. And they've expanded to start providing these services to the whole county. So this is a really exciting, amazing work that's happening locally.
We've been despised, minimized, colonized, and sterilized. We've been jeopardized, merchandised, and disenfranchised. We've been oppressed, suppressed, and depressed. They tried to terminate us, totally eliminate us. No matter what they tried, we survived. Felt cursed the day we were born, babies from parents torn. Our children's hair was shorn, then told we could not mourn. Our language all but gone. God knew that all along. He'd give a spirit song to make our people strong. It's been a holocaust, and many lives were lost. No matter what the cost, our ways they won't exhaust. We have a motivation in every situation, on every reservation, to stand for truth. It's our salvation. Back in the days of old, this story was foretold. We would be bought and sold, yet our ways shine like gold. We have an enemy, he's one we cannot see. His color's always been invisibility. He tried to drug us, dope us, addict us. He robbed us blind, then he tried to convict us. But now revival's come. We hear it in our drum. The message loud and clear, deliverance is near. We give a sacred cry, our ways will never die. We walk the holy path and heal the aftermath. We are the 7th generation, spoken of by sovereign nations. We've been pressed down, but not forsaken. Let there be no mistaken, we have been reawakened.
So with that, I'd like to thank all of you for joining with us today for this conversation. Invite you to continue learning with us on Thursday. I can stay on if there's some questions, but we'll go ahead and we'll end the recording now, and we'll send you all on your way. Thank you so much. Have a fabulous rest of your day.